Good morning, everyone. Thank you, organizers, for this opportunity. My Happy Republic Day, everyone. I have been given two topics, two abstracts, which are hypothesis generating phase 2 studies. Interesting, how can we de escalate or modify, personalize the treatment for our patients of breast cancer? Starting with first is a train 3 study, which is a phase 2 study where image guiding was used to whether we can de-escalate the number of cycles of chemotherapy which we give to our HER2 positive breast cancer patients from Netherlands. We know that we give dual HER2 blockade if possible with chemotherapy to patients for 6 to 9 cycles, with EFS rates now reaching up to 98% in some of the studies. So is it possible to come down number of chemotherapy cycles and still remain EFS of more than 90% was their idea. So they did, we know from Fergain that PET is not a good image modality to predict complete response. So they tried and used MRI. After 3 cycles of dual chemotherapy and dual HER2 directed therapy, patients underwent response evaluation. If MRI showed that there is radiological complete response, then a confirmation was done by a lymph node biopsy or FNAC. If that also at least 2 times it was indeterminate, then it was thought that it is a negative disease and patient was operated. Otherwise, patient was given 3 more cycles, and so on and so forth, up to 9 cycles of TCHP, and then a surgery was compulsory done if up to 9 cycles there was no pathological or complete radiological response. And if on surgery there was no pathological response, patient were compensated by giving TDM1 14 cycles. If there was PET-CR, they were only given TRAS2 maintenance as one would do routinely. Even if after 3 cycles or 1 cycle there was PET-CR, then also they wouldn't receive all the remaining chemotherapy cycles. So primary endpoint was 3-year EFS, which I'm going to present today. They have already presented PATCR previously. This was in the previous abstract. What they could predict that MRI prediction, up to 1/3 of your patients will undergo radiological or pathological complete response by just 3 cycles itself, and 60% by 6 cycles and 73% by 9 cycles. This is if their ERPR is negative. But we know that ERPR positive tumors don't achieve good response. So when ERPR positive on the right side, by diagram, you will see only 29% could achieve radiological or pathological response. Out of this, pathological response was only in 50% of the patients. So MRI still couldn't predict good way of response prediction, even ER positive tumors. But it could do in good turnaround rate, only 88% out of what radiology could predict were really PAT-CR. So MRI could predict good in ERPR negative, but not in ERPR positive or triple positive patients. The outcome are fantastic. The 3 years outcome of all patients, EFS is 92% in both the arms, whether it is ERPR positive or negative, and 3-year OS is 97%. So yes, de-escalating treatment by image guiding is possible. We know we need better image guidings in ERPR positive, but not in ERPR negative. Maybe MRI is optimal. This is hypothesis generating, as I pointed out by starting my talk. In patients who received only 3 cycles, who are very good biology disease, as we say in day-to-day practice, with the 1/3 of patient who could just with 3 cycles achieve PAT-CR or radiological CR, they are doing well, 96% 3-year EFS. And similarly with hormone positive disease, those who could achieve PAT-CR within less number of cycles, they did better. As more and more number of cycles were required, the EFS keeps on dropping. So they are the poor biology disease per se, not that more chemo was did some detriment. As we know, if number of cycles increases, the number of toxicities increases percentage. This was presented before. So they concluded that in 1/3 of your patients, less number of chemotherapy, only 1/3 of your chemotherapy can be required if hormone is negative. In 1/6 of the patient, you can decrease the number of cycles if hormone is positive in HER2 patients. So PAT-CR can be identified with MRI. Fergain, we know, could not predict PAT-CR. Only 62% did not have PAT-CR when PET predicted PAT-CR. So image guided approach can be further be explored, is the hypothesis. What hypothesis they had remains stands. At least in hormone negative, MRI can be used in day-to-day practice, but obviously large trials are required. Coming on to second study, it was the survival outcome of neoadjuvant de-escalation again. Can we avoid chemotherapy in ERPR positive? They were given ET TRAS2 versus de-escalation of 12 cycles of weekly PACLI TRAS2 in hormone positive disease only. So they wanted to see whether 12 cycles can, a chemotherapy-free and de-escalation chemotherapy, that is only 12 cycles, 12 weeks of chemotherapy, can do what we are doing with regular 6 months of chemotherapy. So this is a prospective multi-center study, which all ERPR positive patients were taken. Primary PAT-CR was their first outcome, which they have presented earlier. Even this is the secondary outcome that they have reported here. 3-year EFS I will be reporting today. My topic was. So they were given only 12 weeks of chemotherapy, either chemotherapy with dual HER2 or endocrine therapy with dual HER2. And those who could achieve PAT-CR, they were continued to given all whatever, irrespective of PAT-CR, they were given whatever is normally routinely planned. But their hypothesis was whether only hormone therapy or less amount, how many patients could achieve PAT-CR. The PAT-CR, whatever the primary endpoint was, disappointing. When endocrine therapy was used, only 10% patients could achieve PAT-CR. While if chemotherapy was added, mind you, they were ERPR positive patients also. All were HER2 positive and ERPR positive. But when chemotherapy was given, 50%, roughly 50% could achieve PAT-CR. This they have presented before. To this abstract, they have presented their 5-year EFS and OS. 5-year EFS, OS again looks fantastic. 5-year EFS is 92%. In either of the arm, it is more than 92%. And OS, when you didn't use chemotherapy, is reaching 100% in triple positive patients. So none of whatever they tried univariate analysis was significant, but they did conclude that in triple positive patient, we can give neoadjuvant chemotherapy slightly less number of chemotherapies compared to what we routinely do in our day-to-day practice. But this is hypothesis generating phase 2 study. Thank you.